what are the main advantages and limitations of different types of ULT?
There are different types of U rate lowering agents. Some are xanthine oxidase inhibitors. Some are promoting the reabsorption of urate by trying to excrete more urate from the kidneys. And some are uricase. So let's talk one by one, okay? So for xanthine oxidase inhibitor, the most classical one will be allopurinol. But the problem with allopurinol is for some selected populations, they are relatively well known to development of allopurinol hypersensitivity syndrome, which has a very high mortality, up to 20 to 30%. So this is the main drawback of allopurinol. And the other well-known xanthine oxidase inhibitor is fibrosostat, which has fewer and actually has not much cutaneous side effects. And also the efficacy is much better than allopurinol at a dose of 300 milligrams. So this can be used in patients with chronic renal failure or chronic kidney disease, which less side effect. And for the other, such as the uricosuric agents such as probenecid, benzbromarone, this relies very heavily on the normal kidney functions. For probenecid, if the renal functions is less than normal, say less than 50 ml per minute, then actually probenecid is not much not effective at all. So for benzbromarone, one of the it is also a uricosuric agent and can be used in patients with mild chronic renal impairment. But then the problem is there are some cases of very severe hepatotoxicity. So in the United States, it was not really registered in the market. So and then for those uricase, these are mainly for very sudden high urate very sudden onset of an increased urate level. For example, in patients with having chemotherapy. So these are not really for chronic use. And for uricase such as picoticase, it can only be used as in the form of intravenous use. So that's caused a little bit of problem in the administration. And also when it is used as long-term treatment, sometimes it will develop antibodies. So the effect or the efficacy of the picoticase will lower if the patient has antibody development to the picoticase. So different types of urate lowering agent has different problems. But then for the first line, perhaps xanthine oxidase inhibitor would be our first treatment options because of the easier administrability and also with the high efficacy.
So in the practice, what is the most commonly used ULT?
Historically, we only have allopurinol as the first xanthine oxidase inhibitor, so we normally use allopurinol. But then, because of the worry of a lot of skin or cutaneous side effects of allopurinol, then in patients, particularly in some selected populations such as Han Chinese and also Thai people and also Taiwanese, then perhaps particularly if they have also have renal impairment, then we really need to think about alternatives such as fibrosostat.
So in those with renal impairment, what is your preferred ULT?
In those with renal impairment, either we xanthine oxidase inhibitor is my first choice. And in patients with renal impairment, probably if cost is not a concern, then we will choose fibrosostat. Because in patients with renal impairment, if we are using allopurinol, then we have to start in from a very low dose, say 25 milligram or 50 milligram a day, and then titrate up well, and then we will reassess and monitor the urine level until it is it has reached the target level. So this involves quite a lengthy process, and the patience or adherence to the drug is very important. So for me, I will rather choose dosistat which don't really need a lot of drug titration, and also for patients with reading impairment, it can also be used as a first line option.